So I'd like to invite Dr. Sandeep Gare, who is going to talk about PAC versus ECHO. Sandeep works in Hyderabad in Nizams, and he's presently working at the Sunshine Heart Institute in Hyderabad. Over to you, Sandeep.
Yeah, good evening. It's a honor and privilege to be here today. Thanks to all responsible for this. My topic for today is on pulmonary artery catheter versus transesophageal echocardiography. From the time of inception, we're all aware that TE has come a long way, so much so that we're actually having an entire conference dedicated to it. Indisputably, the usefulness of TE has been established. So my talk is going to mainly focus on whether in this echo era, is there still a need for a pulmonary artery catheter or is it time to bid farewell to it? If you see, the idea of right heart catheterization actually dates back to 1929 when Dr. Werner Fossmann actually placed a urethral catheter through his own vein to measure the pressures on the right side of the heart. And he later on went to win the Nobel Prize in Medicine for his work on pulmonary artery catheter. The present-day balloon-tip flow-directed catheters were first published by Swan and Gans. This was the first time they were using in the ICU without the use of a fluoroscopy. If you see a short note on insertion, in the ICU and the operation theater, insertion is generally guided by the pressure waveforms and not by fluoroscopy. And so once you're 20 centimeters into the sheath, we actually inflate the balloon, and inflation of this balloon directs the pulmonary artery catheter along the blood flow. So once you're in the right atrium, you get the CVP trace, and then when you another 10 centimeters, we're in the right ventricle, we see a systolic increase in the pressures. And then when we move another 10 centimeters, we are into the pulmonary artery. And this is identified by three features. One is there is a diastolic step up in the pressures. Second, there is the appearance of a diacrotic notch. And three, when you see the slope of the right ventricle diastole, it is actually increasing, whereas the slope of the pulmonary artery is actually a decelerating slope. And another 10 centimeter in, you get the pulmonary artery wedge pressure, which is morphologically similar to that of the CVP, but the pulmonary wedge pressures are usually higher and that occurs little later in the cardiac cycle. A lot of information is obtained from the pulmonary artery catheter, and most of them are, some of them are directly obtained and some of them we derive from them. The directly obtained parameters are the CVP, then you get the systolic, diastolic, and the mean pulmonary artery pressures. And when you balloon occlusion of the branch of the pulmonary artery isolates the tip of the pulmonary artery catheter from the proximal PA pressures. As a result, there is a static column of blood right from the pulmonary artery catheter tip up to the left atrium. So pulmonary capillary occlusion pressure is an indirect measure of the left atrial pressure, which is an indirect measure of the left ventricular end diastolic pressure, which tells you about the left ventricular preload. By using the thermodilation technique, we actually get the cardiac output, and also we get another important variable, which is the mixed venous oxygen saturation. And for this, we actually have to deflate the balloon and take the sample from the distal tip and then put it into our ABG machine to calculate the mixed venous oxygen saturation. It tests about the balance between the oxygen supply and the demand. Moving on to the derived hemodynamic parameters, the important ones are the cardiac index. Then you get the stroke volume when you divide the cardiac output by the heart rate. And the other important ones are the systemic vascular resistance and the pulmonary vascular resistance. You get these two and they provide you an estimate of the afterload which is posed on the left ventricle and the right ventricle respectively. Some of the important oxygen delivery parameters are the arterial oxygen content. You need an ABG for this to calculate the arterial oxygen content. And to calculate the mixed venous oxygen content, we need a sample from the pulmonary artery catheter. The difference between these two is what is the arteriovenous oxygen content difference. And when you multiply this difference by the cardiac output, we actually get the oxygen consumption of the body, which tells you how much oxygen is being consumed by the body. To derive some useful information, we actually have to tabulate the data. And let's remember that trends are more important than the actual absolute values. So for that, we actually make two tables. One is having the hemodynamic parameters and other has the oxygen derived parameters. And by looking at the trends, we actually know in which direction the patient is actually progressing. Another important chart which is used is the graph. This one has the pulmonary capillary wedge pressure along the x-axis and the cardiac index along the y-axis. And through a pulmonary capillary wedge pressure of 12, we draw a vertical line, and through a cardiac index of 2.2 or 2.5, we draw a horizontal line. And based on where our patient's hemodynamic parameters fall, we can actually guess his hemodynamic state. So a normal person has a pulmonary capillary wedge pressure of around 12 and a cardiac index of 2.2 or 2.5. If a patient has a cardiac index which is low and also a capillary wedge pressure which is low, it means that he's in a hypovolemic shock and you actually have to give volume to this patient. If the patient has a cardiac index which is low, in spite of having a good capillary wedge pressure, or in fact higher capillary wedge pressure, it means that he's probably in cardiogenic shock and you have to support him by giving some inotropes. In the situation where the cardiac index is high and also the capillary wedge pressure is going to be high, probably this patient is in pulmonary edema and you have to give him some diuretics. And in the situation where you have a cardiac index which is high, whereas the capillary wedge pressure is low or normal, probably he's in severe vasodilatation because of sepsis probably, and you need to give him some vasopressors. So this gives us an idea of what type of hemodynamic disturbance is present, and this guides us in therapy. Another important variable which we get is the mixed venous oxygen saturation. It tells you between the balance of oxygen supply and demand. So looking at this equation, we know that any decrease in the mixed venous oxygen saturation could be either due to a decrease in the oxygen supply, or it could be due to increased consumption, or an increase in the cardiac output, or a decrease in the hemoglobin. So whenever you have a patient with a low mixed venous oxygen saturation, first look at the supply. If the supply is low, correct it. So you need to give oxygen, increase your FiO2 or increase the PEEP. But if the oxygenation is fine, that means that this part of the equation is not right. And so you need to look at the cardiac output first. If the cardiac output is high, then we'll go on to look at the hemoglobin. If the hemoglobin is also normal, it means that probably the patient is in pain or he is stressed out or in anxiety. And so there is increased oxygen consumption. So you have to give him analgesia or sedation. If his hemoglobin is low, transfuse him some PAC cells. On the contrary, if the cardiac output is low, then we need to diagnose why it is low. So look at the pulmonary artery occlusion pressure. If it is low, that means you need to give him some fluids. And if it is high, probably he's in cardiogenic shock and he needs some support through inotropes. So now let us see how we can actually put, in what situations we can put all this information into practice. Pulmonary artery catheters. Yes. Yes, sir.
Sorry to interrupt your flow, but can you turn your video on, please?
Sorry. Sir, am I visible, sir?
Yeah, thank you. Thank you so much.
Yeah. So now, if you see the usefulness of this, a patient, it was initially used for patients with acute coronary syndrome for the optimal therapy, but this was performed before the era of echocardiography and when immediate revascularization was not available. Now it is no more used in this indication. We commonly use the pulmonary artery catheter in ICU. In the ICU, we have a lot of patients who come with hypotension and shock. Whatever may be the reason for hypotension or shock, you're always going to find a pressure with a low systolic blood pressure. We need to diagnose what is the cause for this so that we know what treatment to be given. So a patient with hypovolemic shock, the primary pathology is that there is decreased filling, and so they will have a low CVP and a low capillary wedge pressure. And so the cardiac output is also going to be low, whereas the SVR may be normal or high. So when you look at these things, you know that you have to give fluids to this patient. Whereas in a patient with cardiogenic shock, primary pathology is a decrease in the cardiac output, and because of the back pressure changes, the capillary wedge pressure is increased, and because of the compensatory changes, the SVR is increased to improve the tissue perfusion. So when you look at this, we know that we have to support the heart by giving some inotropes. In the patient with septic shock, the primary pathology is severe vasodilatation, and so his SVR is going to be very low, in spite of having a good or high cardiac index. And the capillary wedge pressure may be normal or no. And in this situation, we actually have to give him vasopressors. Another thing we see in the ICU is that patients commonly have pulmonary edema. And by looking at the capillary wedge pressure, if it is more than 18, we know that it's a cardiogenic cause. And if it's less than 18, it's probably of a non-cardiogenic pulmonary edema. Pulmonary artery catheters have been useful in the preoperative optimization, intraoperative, as well as the postoperative period. They help us in guiding fluid management and also in the choice of inotropes, pressors, dilators, or any diuretic. When a patient has a ventricular dysfunction, you can actually distinguish whether it's left or right ventricular dysfunction. In a left ventricular dysfunction, you have both the CVP as well as the pulmonary artery pressure, which rise, whereas in the right ventricular dysfunction, the CVP rises, and usually the value of CVP is more than that of the pulmonary artery pressure. In patients who are put on LVAD, the LVAD actually unloads the left ventricle and decreases the left-sided atrial pressure, but this simultaneously increases your RV preload, and nearly 20 to 40% of these patients go into right ventricular dysfunction. And having a pulmonary artery catheter in them actually helps us in diagnosis and treatment. So we need to know whether this RV dysfunction is because of an increased PVR or an increased afterload. In that case, we need to give a selective pulmonary vasodilator such as NaL nitric oxide. Whereas if it is due to impaired RV function, we either have to give an RV inotrope or we may have to put the patient off BiVAD.
Dr.
We all know that a
Sorry,
mean pulmonary.
you are offline again. Your video is not seen. Please start it. Thank you. Yes, you are seen.
I'm seen, ma'am.
Yes, no, again you are not seen.
Sorry.
Yes, you are seen. Please go ahead.
Ma'am, but when I'm putting my slideshow, I think my video is going off.
Then it's all right. You continue without video. It's all right.
Yes, ma'am. Okay. So when we have a mean pulmonary artery pressure of more than 25 mm of Hg, it's a diagnostic of pulmonary hypertension. Now, we need to even establish the etiology of this pulmonary hypertension. So for that, pulmonary artery pressures actually, catheter helps us. So in a pre-capillary pulmonary hypertension, the capillary wedge pressure is normal, whereas the PVR is markedly increased, and the difference between your end diastolic pressure and the capillary wedge pressure is more than 5 millimeters of mercury. In the case of a pulmonary venous hypertension or post-capillary hypertension, which is probably due to severe LV dysfunction or in a patient with aortic or mitral valve pathology, due to back pressure changes, you actually have a pulmonary capillary wedge pressure which is high, whereas the PVR is normal or increased, and the difference between this is low. In the mixed type, both your capillary wedge pressure and the PVR are increased, and the difference is also high. So once you have established the etiology, it is more easier for us to guide our therapeutic approach based on this. In a patient with right ventricular dysfunction of any cause, the first thing you're going to see is an increase in your right atrial pressure, and generally it is more than that of the capillary wedge pressure. This right ventricular dysfunction could either be because of a acute RV infarction, or it could be because of an acute increase in an RV afterload. Now, if you have a pulmonary artery catheter, when you have having a person with a pulmonary infarction, we see that the PA waveform has a very narrow pulse pressure because of the decreased right ventricular stroke volume, and the RA, PA, and the pulmonary capillary wedge pressures, they're very difficult to differentiate, and this is quite a distinct feature of RV-MI. Along with diagnosing this, we actually helps us in hemodynamic monitoring of the patient with RV dysfunction. The three parameters of a cardiac output are the preload, afterload, and contractility. And your pulmonary artery catheter is providing all of them. The CVP provides you with the preload, the afterload by the pulmonary pressures, which even helps you in distinguish between the pre and the post-capillary pulmonary hypertension, and the ejection fraction, which you can get with some of the pulmonary artery catheters, tells you about the right ventricular contractility. The mixed venous oxygen saturation actually tells you whether this cardiac output is adequate to meet the metabolic needs of the body. Pulmonary artery catheter is routinely performed for the evaluation of patients, potential heart transplant recipients. Apart from looking at the intracardiac pressures, we also see whether the reversibility of PVR is present or no. And after transplantation, transient RV failure is pretty common, and therapies are generally guided by pulmonary artery catheter. We need to know whether we need to use a vasodilator, we need to use a RV inotrope, etc. And this is all guided by a pulmonary artery catheter. In spite of the numerous uses of pulmonary artery catheter, it has been criticized. And one of the reasons is that it is pretty invasive and high rate of complications. According to the American Society of Anesthesiologists task force, the pulmonary artery catheter, the incidence of serious complications is around 1 in 1,000 to 5 in 1,000. The most common of them are arrhythmias, which are benign, but some of them with a pre-existing left bundle branch can actually go into a complete heart block. A rare complication is pulmonary infarction, which could occur due to distal migration of the pulmonary artery catheter or embolization of a thrombus, which is formed on the pulmonary artery catheter. Another rare but serious complication is an endobronchial hemorrhage, which could occur because of balloon inflation in the distal pulmonary artery due to iatrogenic rupture of the pulmonary artery. When you put a patient on hypothermic cardiopulmonary bypass, the catheter can get stiffened and hardened because of the low temperature, and also because the heart becomes flaccid, there could be some distal migration of the catheter tip leading to rupture of the pulmonary artery. It has a very high mortality rate. Another complication is valvular damage. If you're going to advance the catheter without actually inflating the balloon, you could actually, it will not go along the flow, and actually it can get actually entrapped within the caudate antennae and damage the tricuspid valve apparatus. If you're going to withdraw the catheter actually without deflating the balloon, it could damage the pulmonary or the tricuspid valve. There have been incidences where the pulmonary artery catheter has been shifted right from the SVC to the IVC and then put into the hepatic vein and wedged over there. So transesophageal echocardiography is invaluable in confirming proper placement of this. And one of the most important things is we need to remember is that data misinterpretation and inappropriate therapeutic intervention resulting from these errors is an important complication. Now let's move on to transesophageal echo. In comparison with the pulmonary artery catheter, where we interpret the values or the circumstance based on changes in pressure, transesophageal echocardiography actually gives you a direct view of the heart and the various structures. And we're actually seeing the function of the heart, the valves, etc. You're not assuming anything, you're actually looking at them. So if you see, whatever may be the indication, the most common indication for echocardiographic evaluation is for ventricular function. The echocardiography tells you both about the right ventricle as well as the left ventricular function. And also you can know about the systolic function. And in the systolic, it tells you whether it's a global problem or a regional wall motion anomaly. And of course, echocardiography is the only method to grade diastolic function. You can also have a look at the valves and you can see whether it's any stenosed or it's leaking or any vegetations are present on the valves. If you have a patient who is not performing well or suddenly deteriorating, you can actually have a look at his regional wall motion anomaly. Any increase or sudden increase in the regional wall motion anomaly or a deterioration of a diastolic function is one of the first indicators of ischemia, and you can actually start your therapy at an early stage. It's not that you can just look at the heart and the chambers, but you can also look around. You can look at the aorta, you can look for any pericardial effusions, tamponade, and also it helps in guiding placement of the pulmonary artery catheters, central lines, ECMO, retrograde cardioplegia, just to name a few. If you see some of the common variables which are derived from both, and if you see the strong points of a pulmonary artery catheter are that whenever you need to measure a pressure or a resistance, or when you need the cardiac output, the pulmonary artery catheter is the most reliable one. So when you need the CVP, when you need the PAP or the SVR, PVR, the pulmonary artery catheter is more reliable. And mixed venous oxygen saturation, obviously, you can get it only through a pulmonary artery catheter. And cardiac output by thermodilution is still the gold standard technique. And it has been found that it correlates better rather than the 2D or even the 3D echo. And the strong points of echo are that you can actually see the structures over there. You can comment about the ejection fractions, both the ventricular functions, the valve functions, the diastolic function, and etc. Are there any disadvantages of TEE? We have all experienced situations where ejection fraction, grading of TR, MR vary widely between operators. This is because you actually don't get a numerical value. You see a picture and interpret it. So there could be a lot of operator dependency on that. And also we cannot use it continuously. It needs some expertise to do an echo. And most of the centers are not equipped 24/7 with someone who can actually perform an echo and give you results of an echo. And also you cannot use a transesophageal echo after extubation of a patient. The advantages and strong points of PAC are that it provides three key variables, that is intracardiac pressure, cardiac output, and it also tells you whether this cardiac output is adequate to meet the metabolic needs of the body by looking at the mixed venous oxygen saturation, which tells you the balance between supply and demand of oxygen. And also, since you get a numerical value, it is less operator dependent and it can be monitored continuously. In spite of its versatility, pulmonary catheter has been fading from the cardiac practices. There are many reasons for this, but probably the two important ones are it is very invasive and a lot of complications. But we have seen that the rate of complication is around 0.1 to 0.5% only. And second reason is that inability to produce improved outcomes. So if you look at the literature, probably there was no other diagnostic tool subjected to so much of scrutiny as that of the pulmonary artery catheter. There is a lot of data which tells you about improved outcomes, no difference, and worse outcomes in a variety of settings. The first negative study probably was by Connors et al., who showed that in the support trial that the use of pulmonary artery catheter actually led to increased mortality. And there was soon a backlash which followed, and many editorials with topics such as death by pulmonary artery flow-directed catheter. Is it time for a moratorium? And is it time to pull the pulmonary artery catheter started appearing in some of the leading journals? Actually, if you go through, it is that most of these studies were uncontrolled studies and were used in a heterogeneous population. In carefully controlled studies, it was shown that the routine use of pulmonary artery catheter in any type of setting did not actually lead to improved outcomes. And so this led to a rapid and precipitous decline in the use of pulmonary artery catheter. And further probing, if you see, if you do not use it routinely, but you use it in high-risk surgical population and you optimize your patient based on that, it actually reduced mortality, morbidity, and it was in fact cost-effective. Some of the intensivists actually developed some automated physiological profile or an algorithm to monitor hemodynamics and oxygen consumption using a pulmonary artery catheter, and they found that they could actually reduce the operative mortality in using this. And one, Dr. Shoemaker et al. Found that supranormal oxygen delivery improved outcomes in high-risk surgical population. So we need to remember that the fact is that pulmonary artery catheter at best is a diagnostic tool, and it provides you data that are not easily obtained by any other means. But then why is the lack of outcome? Probably one reason could be a significant deficiency in the physician's knowledge and understanding of the PAC data. A study by Ebert et al. Showed that only 60% of the physician using this could actually identify the correct waveforms. So we need to understand that prognosis of a patient cannot be improved by the presence of a pulmonary artery catheter alone. It has to be coupled with a specific treatment plan, which actually improves the outcome. In 2003, the American Society of Anesthesiologists gave some recommendations for PAC catheterization, and they said that it should be used in appropriateness with a correct patient who has you can consider it in a patient with significant organ dysfunction or major comorbidity. You can consider it in a patient undergoing high-risk surgical procedure where you're expecting large fluid changes or hemodynamic disturbances. Most importantly, it should not be performed by staff in whom competency in insertion interpretation cannot be guaranteed. So possibly the clinical indications for pulmonary artery catheter today can be patients with right-sided heart failure, pulmonary hypertension, severe left-sided heart failure, patients in shock, patients undergoing heart transplantation, and LVAD implantation. We need to remember that all our hemodynamic goals are finally to meet the oxygen or the metabolic needs of the body by modifying the cardiac output, etc. And the cardiac output has three determinants mainly: the preload, afterload, and contractility. And pulmonary artery catheter is giving you quite a few of these variables. It tells you about the preload, the afterload, the cardiac output, and it also tells you about the mixed venous oxygen saturation, which tells you about whether this output is enough or no. So in conclusion, I would like to say that knowledge is power only if we know how to utilize it. And patient selection and tailored therapy is still an art and is highly operator dependent. Transesophageal echocardiography and pulmonary artery catheters are not here to compete with each other. Definitely, TE must be used routinely for each and every case. However, we can use pulmonary artery catheter should be used in selected situations to complement the transesophageal echocardiography data. Thank you.